cat liver, abdominal pain, lethargy, sweats. 2 weeks. Posterior triangle lymphadenopathy. Is it some sort of fungal infection from cats? What infection can you get from cats? Bartonella. What's that? The rest doesn't seem very likely. Cystic hygroma. I believe you're born with that. TB. You don't get that from cats. Branchial cyst. It's a congenital one. The rest doesn't sound like cat origin. Anterior border of sternocleidomastoid muscle. Intermittent. Soft and fluctuant. It's a cystic lesion. Pharyngeal pouch. Branchial cyst. I leave this cyst directly under the sternocleidomastoid. Mass in the midline of the neck. Moves upward on tongue protrusion. This has to be thyroglossal cyst. Let's check the answers. Bartonella infection may occur following a cat scratch. Intracellular.
Hey everyone, this is we're talking about cat scratch disease. You might have heard of this as cat scratch fever, but cat scratch disease is an infection caused by the intracellular bacteria known as Bartonella henselae, which is a gram-negative bacteria. Here is an image of that bacteria. Now, this is why this disease can be referred to as Bartonellosis because of an infection with Bartonella. Now, cat scratch disease, as its name implies, is that it is cat-to-human transmission. That means that we can get cat scratch disease from a cat through a scratch or a bite. Now, cats are the natural reservoirs for Bartonella henselae, but fleas are actually a vector of transmission. So fleas can actually pass Bartonella henselae from cat to cat. So if our cat is an indoor cat that has never been outside, has never been exposed to fleas, it's less likely to carry this bacteria. Now, when a human does get infected with Bartonella henselae through a cat scratch or a cat bite, that bacteria, the Bartonella henselae, will invade the endothelial cells in that person. It will lead to an acute inflammatory reaction. It leads to the activation of a pro-inflammatory cascade, which will cause some of the symptoms we're going to talk about in the next slide. So what is the clinical presentation of cat scratch disease? One of the biggest ones is a skin lesion. This makes sense. If we get bit by a cat or scratched by a cat, there's a lesion. But there's a particular lesion with cat scratch disease, and it occurs generally 3 to 10 days after inoculation of the bacteria. It leads to a fascicular or an erythematous or papular lesion. And this lesion will stick around for about 1 to 3 weeks. The lesion looks like this. So in these pictures, we see possible cat scratch here, and we get these little papular type lesions. This is the characteristic look of the skin lesion in cat scratch disease. Now, another big symptom that we see in cat scratch disease that usually is the defining symptom in this disease is regional lymphadenopathy. This usually occurs 2 weeks post-inoculation. So after about 2 weeks after the individual has been inoculated with the bacteria, we start to see this regional lymphadenopathy. It is proximal to the inoculation, and it is tender. So we generally, if a cat scratch or bite occurs in the arm, we can see this tender proximal lymphadenopathy, usually in the axillary nodes. So we can see this picture here, that we get this tender lymphadenopathy, axillary nodes, proximal to the inoculation. So this is a key presentation in cat scratch disease as well. And the third most common symptom is a fever. That's why cat scratch disease is considered a febrile lymphadenopathy, fever with regional lymphadenopathy. And if you see an unexplained fever in an individual, perhaps they have cats, think about this as a possible cause. Now, other than these 3 most common signs and symptoms, there's also certain instances where individuals can have a disseminated disease, a disseminated cat scratch disease. And it's unsure about the pathology, the pathophysiology as to why this happens, but a subset of patients can get dissemination of their cat scratch disease. It can lead to hepatosplenomegaly, so an enlargement of their spleen and enlargement of the liver. They can get retinitis, an inflammation of the retina in their eyes, and they can also get encephalopathy. So again, this occurs in rare instances, but it can be caused by cat scratch disease or can be a dissemination of the cat scratch illness. But generally, in most cases, and most often, it is a self-limiting disease. So generally, patients only get skin lesions, regional lymphadenopathy, and fever, and it often is a self-limiting disease. So how do we diagnose and treat cat scratch disease? Diagnosis involves serology. We look at IgM and IgG levels. IgM and IgG serology has low sensitivity but a high specificity. So if we see IgM or IgG antibodies to Bartonella henselae, we can affirm that they have a diagnosis of Bartonellosis or a diagnosis of cat scratch disease. PCR can also be performed to look at DNA or genetics involving B. henselae. Lymph node biopsy can also be performed, although this is generally not required, just because if we can see the history and get good serology and a possible PCR, we may be able to make a diagnosis. Treatment is generally supportive. Oftentimes, this is a self-limiting disease. We often leave it. We provide supportive treatment. However, if there's lymphadenitis, so if we get lymphadenopathy, if it's moderate to severe, if the patient's very ill, or if the patient is immunodeficient, we want to treat this. We want to treat it with azithromycin for 10 to 14 days. And if this is a disseminated disease, if it's a severe case of disseminated disease of cat scratch disease, we want to give azithromycin or doxycycline with rifampin. So that's the only difference. We add rifampin or we use doxycycline and rifampin for disseminated disease. So anyways, guys, I hope you found this lesson helpful. That was a lesson on cat scratch disease. If you found this lesson helpful, please like and subscribe for more videos like this one. And as always, thanks so much for watching.
Bartonella Hensley is a zoonotic bacteria which may cause cat scratch disease, or CSD, in humans. Zoonotic bacteria refers to any bacteria which can be transmitted between animals and people. Now, Bartonella Hensley spreads between cats with the help of a cat flea called Tenocephalides felis, which feeds on the blood of an infected cat. Then, it drops its feces, which contain Bartonella Hensley, onto the cat's body. Finally, when the cat grooms or scratches, Bartonella Hensley gets on its teeth and claws, and the cat may infect a human by scratching or biting, hence the name cat scratch disease, or cat scratch fever. There's also bacillary angiomatosis, which is a severe form of cat scratch disease that develops primarily in immunocompromised individuals. Now, Bartonella Hensley is a gram-negative bacillus. In other words, it's a rod-shaped bacteria that stains red or pink with gram staining. This is largely due to the fact that Bartonella Hensley has a thin peptidoglycan wall that doesn't retain crystal violet dye during gram staining. Sometimes, though, it doesn't readily gram stain, so the silver nitrate-based Warfarin starry stain is used for direct visualization. Bartonella Hensley is a facultative intracellular bacteria, which means that it's adapted to live inside cells to avoid the immune system. Specifically, it hides inside endothelial cells lining up the interior surface of the blood vessels and lymph vessels. Once inside the endothelial cell, Bartonella Hensley can trigger an increased production of interleukin 10, which suppresses the action of immune cells, and interleukin 8, which promotes endothelial cell proliferation. In humans, the response to infection depends on the immune system. Immunocompetent individuals develop a simple form of the cat scratch disease. The most characteristic symptom is the swelling of a single lymph node or a cluster of lymph nodes, usually in the armpits, which are extremely painful to the touch. This is known as regional lymphadenopathy, and it's a consequence of Bartonella Hensley triggering a never-ending T-cell response, which creates an area of inflammation known as granulomas in the lymphoid tissue. Other symptoms include fever, fatigue, abdominal aches, and loss of appetite. Additional symptoms may appear when the bacteria spread to the bloodstream, and from there to different organs, causing complications. For example, if it reaches the heart, it may cause endocarditis, and signs include prolonged fever and new heart murmurs on physical examination. Alternatively, if bacteria infect the central nervous system, there may be confusion, disorientation, and seizures. Immunocompromised individuals, on the other hand, like those that are HIV positive, tend to develop a severe form of cat scratch disease called bacillary angiomatosis. With bacillary angiomatosis, endothelial cell proliferation leads to benign papular vascular lesions on the skin. This is especially common in HIV positive people whose CD4 positive cell count is less than 100 per cubic millimeter of blood. These skin lesions are very similar to those seen in Kaposi sarcoma, an endothelial malignancy that frequently develops in HIV positive individuals with a human herpes virus type 8 infection. The difference between these two lesions lies in what inflammatory cell is mostly present in the lesion. In bacillary angiomatosis, the inflammation is mostly made up of neutrophils, whereas in Kaposi sarcoma, the inflammation is made up of lymphocytes instead. Other symptoms of bacillary angiomatosis include fever, chills, fatigue, and weight loss. Complications may arise from bacillary angiomatosis when the lesions cause disfigurement, or when the lymph nodes inside the body become enlarged. For example, enlarged lymph nodes around the portal vein can compress the common bile duct, causing biliary obstruction and jaundice. Finally, if an angiomatous nodule forms in one of the eyes, it could cause unilateral vision loss. Bartonella Hensley infection is usually diagnosed by indirect fluorescence assay testing, or enzyme-linked immunoassay, to look for serum antibodies against Bartonella Hensley. Alternatively, a biopsy of affected tissue, either a swollen lymph node in cat scratch disease or a skin lesion in bacillary angiomatosis, can be done, and the tissue can be stained using the Warfarin starry method to directly visualize the bacteria. Treatment is aimed at reducing symptoms, since cat scratch disease usually resolves on its own over a few months. However, antibiotics like azithromycin are sometimes used to prevent life-threatening complications. Other alternatives like doxycycline and rifampin can also be used to treat the disease. Antibiotics like erythromycin, doxycycline, and tetracycline are used to treat bacillary angiomatosis. Finally, a means of preventing infection in humans is elimination of fleas in a domestic cat's environment. Alright, as a quick recap. Bartonella Hensley is a gram-negative bacteria found in cats. It can be visualized with the help of a Warfarin starry stain. And it's responsible for causing cat scratch disease, or CSD, in immunocompetent individuals, and bacillary angiomatosis in immunodeficient individuals. Cat scratch disease presents with regional lymphadenopathy, fatigue, and fever. And antibiotics like azithromycin, doxycycline, and rifampin can be used in treatment.
A 25-year-old female student brought to the emergency department. Complaints of severe abdominal pain. Pain started 3 hours ago while she was shopping. Had not had periods for 7 weeks. Currently sexually active. History of pelvic inflammatory disease 5 years ago. Generalized guarding, signs of peritonism. So there's local peritonitis here already. Generalized guarding is not just local peritonitis, but generalized peritonitis. Free fluid in the pouch of Douglas. Empty uterine cavity. So probably an ectopic pregnancy going on. And has it ruptured? Because there's free fluid in the pouch of Douglas, could be the blood from ruptured ectopic pregnancy. Other basic bloods are sent. Very ill. Observations, blood pressure is low. She's going into shock. The hemorrhagic shock. Heart rate raised. Respiratory rate higher end of normal. Oxygen saturation low. Resuscitate and arrange emergency laparotomy, laparoscopic exploration. What is the difference between laparotomy and laparoscopic? Oh, okay, laparoscopic means it's how do you say this? It's a keyhole surgery. This is open straight away. Which one is more appropriate? In an emergency setting, I think exploration would be more appropriate. Yeah. No. The answer... Oh. What did I answer? I said the correct answer, but I chose the wrong answer. So... should be laparotomy. Yeah. The clinical picture shows a high suspicion of ruptured ectopic pregnancy. She turned very ill and went into shock. Laparotomy needs to be considered. Next question. 15-year-old girl reports heavy menstrual bleeding since menarche when she was 14. She was younger. She frequently suffered from heavy nosebleeds. Normal examination and ultrasound. What is the most important next step? Probably some coagulation disorder, because other than heavy menstrual bleeding, she also has nosebleeds. So you want to test. What are the other options? Biopsy? Nah, nothing to biopsy here. Thyroid hormone, would it cause clotting disorders? It will cause menorrhagia. Hypothyroidism can cause menorrhagia, but it wouldn't explain the nosebleeds. Reassurance that menstrual flow can be variable during puberty. Well, it can be variable, but in her case we need to investigate. It's been 1 year. Serum ferritin level. Well, that would help if it's investigating iron deficiency, I guess. But that wouldn't find out the cause of her bleeding. So the answer is blood test for coagulation disorder. Von Willebrand disease. 17-year-old student from Poland is attending his new starter occupational health appointment at medical school in London. He provides a list of his vaccinations, which includes vaccination against tuberculosis. Mantux test is conducted and assessed a few days later. It appears that the student has a negative result. False negative Mantoux test. It could be immunosuppressed. Ulcerative colitis is treated with immunosuppressants. So if it's well managed, it's probably taking immunosuppressants. Well-managed COPD, sometimes they will be on steroids and SABA and LABA. However, inhaled corticosteroids will have less immunosuppressive effects than a oral one. So the correct answer is well-managed ulcerative colitis. What's the management of ulcerative colitis? It seems that long-term prednisolone is the treatment. Can include long-term use of corticosteroids. However, COPD is unlikely in a patient of this age. Oh yeah, it's only 17. It's only 17. Usually COPD will suspect in somebody over 35 who has a long smoking history. Let's study a bit on ulcerative colitis management. Ulcerative colitis is a chronic, relapsing, remitting, non-infectious inflammatory disease of the GI tract. It is characterized by diffuse, continuous, superficial inflammation of the large bowel limited to intestinal mucosa. Usually affects the rectum, with a variable length of the colon involved proximally. Why are you measuring C. diff? Is it as a differential diagnosis? Fecal calprotectins is something released by neutrophils. if you have intestinal inflammation. It's like a screening test, I guess, for inflammatory bowel diseases. Okay, we're interested in the specialist management, confirm ulcerative colitis. This is a review in primary care and specialist treatments. Proctitis is just the rectum, right? Just the rectum. You try topical first. If it doesn't get better in 4 weeks, then you can do it. You can give oral aminosalicylates. So ideally, you don't want them to be on long-term corticosteroids. You want to taper them off of it. Those who are unable to stop within 3 months means when you stop the corticosteroid, the flare-up comes back. We call them, this is termed as corticosteroid dependency. So they become dependent on the steroids. More or less the treatments seem to be similar to Crohn's. It's just that in Crohn's, you wouldn't use aminosalicylates topically. What do you prefer in Crohn's again? Yeah, you prefer corticosteroids. If it doesn't work, then only you go for aminosalicylates. But in ulcerative colitis, you would start with aminosalicylates and a topical one. If it doesn't work, you're gonna try the oral one. If that doesn't work, then you're gonna try adding steroids and other stuff. Yeah. So I'm just curious about how aminosalicylates work. Mesalazine. Mesalazine. Pharmacodynamics. Doesn't explain anything. Probably mechanism of action is not well understood yet. It's one of the two components of sulfasalazine. The other being sulfapyridine. Sulfapyridine is responsible for the majority of side effects. That's why they only use the mesalazine part of the sulfasalazine. Mesalazine is known to be the active moiety in the treatment of ulcerative colitis. They don't know how it works yet. They just know that it works. So more research needs to be done on that. "32-year-old female, 36 plus 1 week pregnant." So 36 weeks and 1 day pregnant. Sudden onset shortness of breath, pleuritic chest pain. Left calf had been swollen for the last 2 days. There's a DVT going into a PE. Hemodynamically stable. Respiratory rate 30. High. Oxygen saturations normal. Duplex ultrasound scan. Deep vein thrombosis. Which of the following actions should you perform next? Should you order a CTPA? Or straight away start with treatment dose of low molecular weight heparin. There's no harm ordering it first and then initiating a treatment dose. But the rationale is you need to do a PE well score, I think. And then if it's above the threshold, which I don't remember the threshold, then you would order a CTPA. If it's below, then you would order a D-dimer. And if you can't do CTPA within the next 3 hours, I think, you gotta start treatment with low molecular weight heparin anyway. I don't know, it's either CTPA or low molecular weight heparin. Oh no, wait. She's pregnant, so you wanna reduce the radiation dose on her. VQ scan is preferred over the CTPA in this case. Let's see what's the answer. The answer is initiate treatment dose. So the answer is always treat first, then investigate. So you don't want to waste time ordering the investigation even. You want to straight away treat first, then consider investigations. Is it only for pregnant women that we do this? Let's say the general one. There's a 2-level DVT well score and a 2-level PE well score. 2-level DVT well score. DVT is likely if there's 2 points or more. And these are the things to look out for. Two-level PE well score has to be 5 points or more. Then you'll say that PE is likely. And these are the things to look out for. So nice guidelines say you want to do CTPA first, if possible, immediately. Or for people with allergy to contrast or severe renal impairment or high risk from irradiation, maybe somebody who's pregnant, you want to do a VQ SPECT instead. Ventilation perfusion scan, single photon emission CT scan or VQ SPECT scan. If it's not available, VQ planar scan as an alternative to CTPA. If it cannot be done immediately, then offer interim anticoagulation. However, in pregnant women, you would want to treat immediately based on RCOG guidelines. Let's look for an appendix. Might show us a flow chart. Yes, this is what we want to find. So if you suspect PE, do a clinical assessment, perform chest x-ray and ECG, test FBC or any LFT, commence low molecular weight heparin, unless treatment is contraindicated. Then only investigate. So for pregnant women, you would want to follow the RCOG guidelines and treat straight away before investigating anything, even before the duplex ultrasound. In this case, they went ahead and do the ultrasound scan first. Ideally, according to the guidelines, you would straight away treat if you suspect it based on history and physicals alone. Next question. During your night shift, you are called to see a 19-year-old man complaining of severe abdominal pain. He received an allogenic bone marrow transplant 10 days previously. You note a tender maculopapular rash, primarily confined to his neck, the palms of his hands and the soles of his feet. Type 7 stools. What are type 7 stools? We'll find out later. I think it's watery stools. More of the diarrhea kind, I think. Given the clinical history and features, what is the most likely diagnosis? So the clinical history, he had a transplant 10 days ago. Probably he has been given some immunosuppressant medications prior to the transplant. What causes a rash? A tender rash. A rash that is painful when you press on it. Confined to his neck, palms, and soles. Viral gastroenteritis. Possible, but it wouldn't cause the rash, usually. Graft versus host disease. I need to study on this, I forget already. Acute mesenteric ischemia. He's too young for this kind of thing, I think. Plus it's a bone marrow transplant. Wait a minute. Nah, I don't think so. Aplastic crisis. I need to study the complications of transplant. Sepsis of unknown origin. Aplastic crisis. I think it could be graft versus host disease. I'll guess this one. Reason being, I don't think the rest will cause any rash. Aplastic crisis, from the term itself, I would guess that it means you stop producing red blood cells, white blood cells, and platelets. That rationally, logically thinking, if you think simplistically, that wouldn't cause much of a rash. Acute mesenteric ischemia, that wouldn't cause a rash. Sepsis of unknown origin, it's very general. There's no mention of him being hypotensive or being feverish. It's still possible. But again, the skin changes. The rash on his neck, palms, and hand and soles makes me want to pick this. So let's try this and learn from our mistake. Oh, it's correct. So the answer is graft versus host disease. Painful macular papular rash is a common feature of graft versus host disease. The above symptoms coupled with a painful macular papular rash should make you think of graft versus host disease, GVHD, in a patient with a recent history of allogenic bone marrow transplant. Viral gastroenteritis could certainly present with acute abdominal pain and watery diarrhea. However, it would not present with this particular rash. The same also applies to acute mesenteric ischemia. It would also be very unlikely in this age group, with no pro-thrombotic factors. Aplastic crisis secondary to parvovirus B19 infection in patients with sickle cell disease can present with a rash and acute abdominal pain. However, the question specifically mentions an allogenic bone marrow transplant, and there is no mention in this patient's history of a sickle cell disease. Oh, okay, so a plastic crisis, you can also have a rash. It's usually in people with sickle cell disease infected with parvovirus B19. In this case, it's only a plastic crisis of the red blood cells then. Sepsis of unknown origin can also present atypically in hematological patients. However, there is not enough information in this question to make this diagnosis. Yes, there's no mention of any fever, no mention of shock, no mention of the patient being very unwell. So let's read a little bit about graft versus host disease. Need to revise a bit on this. Graft versus host disease is a multi-system complication of allogenic bone marrow transplantation. Solid organ transplantation. So graft versus host disease is sort of like the reverse of transplant rejection. In transplant rejection, your own immune system goes and attacks the organ that has been transplanted into you. In graft versus host disease, the reason graft is mentioned first is because the graft is the bone marrow containing all the immune cells. So when it's transplanted to the host, the immune cells from the bone marrow goes and attack the host. So that's why it's graft versus host disease. Prognosis is generally poor. So there's a criteria here, Billingham criteria, to diagnose graft versus host disease. Transplanted tissue contains immunologically functioning cells. The recipient and donor are immunologically different, and the recipient is immunocompromised. Incidence vary from 9 to 50%. It's quite high. Acute and chronic graft versus host disease are considered separate syndromes. Be right back and to bring my dog out. What does de novo mean? New. So graft versus host disease after bone marrow transplant has been arbitrarily divided into acute and chronic at the 100 days timeline. So before 100 days, it's called acute, and after 100 days, it's called chronic. In acute, usually the skin is affected more than 80%, and they have worse prognosis. There's a star here, so I'm going to see what it means. Yeah. So there's some contention about whether the time frame should be used. So you need to base the diagnosis on clinical manifestation and time frame, not just time frame alone, because that doesn't make any sense. "24-year-old nulliparous female with a history of recurrent deep vein thrombosis presents with shortness of breath. HB is normal. platelets normal? No, platelet is low. Normal is 150 to 400, right? White blood cells, normal. PT, PT is usually 10 to 14. APTT is 25 to 35. What is normal? APTT is raised. So the intrinsic pathway is affected. But then he has recurrent deep vein thrombosis. No, this is paradoxical. Your APTT is raised. You expect them to have a bleeding disorder. However, this patient is having clotting disorder, where it's forming deep vein thrombosis, and now shortness of breath, probably pulmonary embolism. What is the most likely underlying diagnosis? Oral contraceptive pill wouldn't cause raised APTT. I don't know about third generation. I didn't know there are generations. Protein C deficiency. Can't remember. Protein C, protein S, what are these things? Just remember the names. Need to study that. Antithrombin 3 deficiency. Antithrombin 3. From the name, it should inhibit thrombosis because it's an antithrombin. Deficiency of this would promote clotting. However, it wouldn't cause a raised APTT. Antiphospholipid syndrome. This is quite special clotting disorder. Is when you have you produce antibodies against anti-cardiolipin and another beta something molecule, and the end result is that it causes you to be prone to platelet aggregation. But how would this affect the APTT? I think this is the one with the strange results for APTT, but it's a clotting disorder. Let's see. Anti-Phospholipid Syndrome, paradoxically. Prolonged APTT plus low platelets.
medicine is so much more. In Anti-Phospholipid Syndrome, individuals produce antiphospholipid antibodies, which attack the phospholipids in the cell membrane of their own cells, or attack proteins that are bound to those phospholipids. So Antiphospholipid Syndrome, or APS, is an autoimmune disease. Antiphospholipid syndrome can be primary or secondary. Primary antiphospholipid syndrome happens by itself, whereas secondary antiphospholipid syndrome happens with other autoimmune diseases, especially systemic lupus erythematosus. And just like most autoimmune diseases, antiphospholipid syndrome is more common in young females. The exact cause of antiphospholipid syndrome isn't known, but there are some known genetic and environmental factors. For example, the HLA-DR7 gene encodes a specific type of protein called the major histocompatibility complex, or MHC class II, which sits on the surface of the B cell. These surface proteins help activate B cells so that they can start producing antibodies. Now, having a mutated HLA-DR7 gene predisposes individuals to activate B cell production of antiphospholipid antibodies. But the presence of the mutated HLA-DR7 gene alone isn't enough to develop antiphospholipid syndrome. An environmental trigger must also be present. And there are a variety of potential triggers. Some common ones include infections like syphilis, hepatitis C, HIV, and malaria, drugs like some cardiovascular drugs, including procainamide, quinidine, propranolol, and hydralazine, or antipsychotic drugs like phenytoin and chlorpromazine. The main antiphospholipid antibody is anti-beta-2 glycoprotein 1, which targets the protein beta-2 glycoprotein 1, also called apolipoprotein H. This protein binds to phospholipids and inhibits agglutination, which is when platelets clump together to form blood clots. So when anti-beta-2 glycoprotein 1 binds beta-2 glycoprotein 1, it's not free to do its job, and that leads to clot formation. Another antiphospholipid antibody is anticardiolipin, which targets a lipid protein in the inner mitochondrial membrane called cardiolipin, which binds beta-2 glycoprotein 1. Anticardiolipin antibodies are also present in syphilis, and that causes a false positive test for syphilis. Autoantibodies might also target blood components. If platelets are targeted, it can lead to thrombocytopenia, and if red blood cells are targeted, it can lead to anemia. So the antiphospholipid antibodies lead to a hypercoagulable state, meaning that they cause thrombosis, or blood clots to form within arteries and veins. Arterial thrombosis is more common in males, and can cause a heart attack, stroke, or limb ischemia. In addition, individuals might develop Liebman-Sachs endocarditis, which is where vegetations form, which are a mixture of immune cells and blood clots, usually on the mitral valve. Venous thrombosis is more common in females, and typically presents as a deep vein thrombosis. Sometimes a part of the main clot might break free and become an embolus, which is where a blood clot travels downstream. Since lung capillaries are very small, this embolus could get stuck, causing a pulmonary embolism. This is a life-threatening situation because it literally blocks blood from getting into the lungs to pick up oxygen. Another organ with very small capillaries is the kidneys, so individuals might develop renal failure. A typical skin finding in antiphospholipid syndrome is livedo reticularis, which is caused by swelling of the venules due to clots obstructing them, and appears as a mottled purplish discoloration of the skin. Women affected by antiphospholipid syndrome tend to have pregnancy-related complications that can lead to a miscarriage. This can happen due to thrombosis leading to placental infarction. For reasons that aren't completely understood, antiphospholipid antibodies are thought to cause neurologic symptoms, like headaches and seizures. In rare cases, antiphospholipid syndrome leads to rapid organ failure due to generalized thrombosis, and this is called catastrophic antiphospholipid syndrome, and can lead to death. Diagnosing antiphospholipid syndrome requires meeting at least one clinical and one laboratory diagnostic criteria. The two clinical criteria are history of thrombosis and pregnancy complications, while the three laboratory criteria are presence of anticardiolipin, anti-beta-2 glycoprotein antibodies, or lupus anticoagulant in the blood. Now, lupus anticoagulant assay is a funny name, but it does have an explanation. It's called lupus because it was initially found in people affected by systemic lupus erythematosus. And it's called anticoagulant because it acts as an anticoagulant in vitro, even though it's a procoagulant in vivo. This is because phospholipids are presence of anticardiolipin, anti-beta-2 glycoprotein antibodies, or lupus anticoagulant in the blood. Now, lupus anticoagulant assay is a funny name, but it does have an explanation. It's called lupus because it was initially found in people affected by systemic lupus erythematosus. And it's called anticoagulant because it acts as an anticoagulant in vitro, even though it's a procoagulant in vivo. This is because phospholipid-rich platelets, which are only found in vivo, are needed to activate coagulation factors and cause a clot. In vitro, on the other hand, which is tested using the Lupus Anticoagulant assay, the individual's plasma is mixed with normal pooled plasma and clotting time is assessed. The pooled plasma doesn't have many phospholipid-rich platelets, so individuals with antiphospholipid antibodies end up prolonging the clotting time. In vivo, there are plenty of phospholipid-rich platelets around, so the effect is excessive clotting. Treatment of antiphospholipid syndrome is aimed at
So in the test tube, because the platelets don't have a lot of phospholipids on them, the antibodies in antiphospholipid syndrome actually causes blood thinning, prevents clotting. However, in our body, which is in vivo, it promotes clotting because there are lots of phospholipids on our platelets. Okay, fair enough. You see a 10-year-old girl who has asthma. She has used salbutamol inhaler for the past 12 months. She finds that she needs it when she is running outside, particularly in cold weather. Her mom is concerned as over the last 6 months she is needing to use it more frequently and has needed to use it at night. She has noticed that she sometimes wakes up coughing and her wheeze is worse in the morning. On average, she is using her inhaler 3 to 4 times a week. You want to step up her treatment. What's the most appropriate next step? So what is her treatment now? She has salbutamol. Is that all? She only has salbutamol, so you can add a low dose inhaled corticosteroid. Is it pediatric? Yeah. Wait a minute. When we use LTRA, I think after you start low dose steroid. Let's see. Oh, there's a less than 5 years and more than 5 years. Child aged less than 5 years with asthma not controlled by a SABA. 8-week trial of pediatric moderate dose. Huh? Moderate dose? This patient needs maintenance therapy as her asthma is uncontrolled on salbutamol. She is requiring a short-acting beta-2 agonist more than 3 times a week and has nighttime symptoms. The next step is pediatric low-dose inhaled ICS. Therefore, the correct answer is option 1, starting low-dose ICS. The next step would then be adding a leukotriene receptor antagonist, in addition to the ICS. After that, you will consider long-acting beta-2 agonists. The latest one is NICE guidelines, February 2020. Where is the table? Do I download this? The table is not here. Maybe under tools and resources. Summary versions, yes. So under 5, you start with SABA if they don't really need maintenance therapy. If it's uncontrolled, you add pediatric moderate dose ICS. This is for under 5. But the case just now was a 10-year-old. Stop it after 8 weeks and review response. If it responded but reoccurred within 4 weeks of stopping the ICS, you're gonna give pediatric low dose with the SABA. If symptoms resolved during the trial but recurred beyond 4 weeks after stopping the ICS, repeat the 8-week trial of pediatric moderate dose ICS. If symptoms did not resolve, review whether an alternative diagnosis is likely. Okay. Then if it's uncontrolled using low dose, add LTRA. If uncontrolled under LTRA, stop the LTRA, continue low dose ICS, refer. Okay, so this is for under 5. Let's look at 5 to 16. No, this is objective test. Pharmacological treatment. So for children aged 5 to 16, if it's short-lived wheezes, consider giving SABA alone. If uncontrolled, for pediatric low-dose ICS with SABA. If uncontrolled, add LTRA. If uncontrolled, Add LABA, stop LTRA. If uncontrolled, change ICS and LABA to a MART. If uncontrolled, up the dose of ICS, either using a MART or separately. Plus LABA. Hey, wait. Change to SABA. It's getting quite confusing here. Over here you don't have SABA anymore. You stop the SABA. Over here you up the moderate dose. From low dose you go up to moderate dose ICS. You either do this separately using moderate dose ICS plus LABA, or you give it in the MARCH regimen. MARCH means maintenance and reliever therapy. Or you give as a fixed dose. If you choose not to give the MART, then you have to change it to SABA. If this doesn't help, then you wanna refer. And they might consider high dose ICS plus LABA. Okay. Next question. Terry is a 76-year-old man who has recently had a stroke and is being prepared for discharge from the ward. The occupational therapist wants to know how Terry will cope at home with activities of daily living. Which measures should they use to best assess this? Okay, let's see what we know. CUP 65 is for severity of pneumonia, so that's out. CHATS VASC score is for what's this for again? Risk of thrombosis, is it? Or is it risk of bleeding? One of them. It's definitely not assessing ADLs. Aptt, risk of bleeding. So this should be risk of clotting. Is risk of bleeding? Or is it risk of TIA? Is the CHATS VASC score risk of TIA? And then the Aptt score is risk of bleeding. So that's out. Frailty index or Barthel index. Which one of these assesses ADLs? Frailty index sounds right. Barthel is named after somebody, so I have no idea how right this is. I'm just gonna go with frailty index. So the answer is Barthel index. Barthel's index is a scale that measures disability or dependence in activities of daily living in stroke patients. Oh, I was wrong. To identify which patients with atrial fibrillation require anticoagulation. Oops, I gotta go. Thanks for staying with me.